So with that said, I'd like Vicki Mandel-King to come up and introduce our speaker.
With pleasure. Good morning. We at Compassion and Choices know that dying is part of life, and while we want to live each day in the present moment, we know we have to plan for a future that we'll all eventually face. Janice Michon has been an RN for 32 years, has worked in the ER and other primary care facilities. Presently, she is the Senior Care Coordinator for Kaiser Permanente, and she serves on the Boulder County Senior Advisory Board. From her experience, she knows that advanced directives help to alleviate the suffering of the dying and of their loved ones. She knows that these directives can avoid life-prolonging measures that are only at high cost and have little gain. She knows that these directives can help our healthcare professionals to go along that healthcare continuum from saving life to allowing all of us to have a dignified and graceful death. Today, Janice will share with you her knowledge, her experience, and I can tell you from my conversations with her, her real passion for this subject and helping all of us. Please help me welcome Janice Michon.
In order to see this better, is there any way to dim the lights? At least in front.
No.
Is that better? You guys can still see? Okay, great. Just a little closer. You guys can hear me now?
Yes.
Yes. Okay, great. Thank you for the introduction. That was very kind. A senior care coordinator, basically we deal with end-of-life issues. We follow patients as they go through the different stages of life and make recommendations as to what kind of care they need for the future. I do work at Kaiser Permanente. I've been there for 28 years. I do want to say I do represent myself and not Kaiser, although I think they do a fantastic job. Don't tell anybody. Okay. Advanced directives, thinking and talking about the hard stuff. I will be flipping through some slides a little fast because I have a lot to cover. Make notations, questions at the end, happy to answer. I will also be answering questions personally in the back. So anyway, thanks. Let's talk about history. In 1900, the average longevity in the United States was almost 50 years. 2 years ago was 78. What made the difference is gains through sanitation. People weren't getting typhus and bad nasty things, and childhood immunizations. Since 1960, we now have all kinds of things that can prolong our lives. Surgeries, procedures, antibiotics, chemo, hypertension, medications, which make a huge difference in longevity. But people die differently. As you can see, the cause of deaths in 1900, most of the first three were basically communicable diseases. The last two were more lifestyle related. 31% were relatively quick, contagious diseases, and only 14% were lifestyle. Okay. 2004. Look at things how they've changed. Heart disease, cancer, strokes being the top three. My son likes magic cards, so I put lingering death on there. There's 61% are lingering deaths. You'll notice that there's no contagious diseases that occur in the first three top causes, and most of them were lifestyle related. I did put cancer in lifestyle related because sometimes cancer just happens. But what they're finding out, a lot of it is lifestyle. Lung, bladder, kidney, stomach, esophageal, oral, lymphoma are all related to smoking, or at least partially. It definitely puts you more prone to it. breast cancer, weight, lack of exercise, high-fat diet, alcohol consumption, hormone replacement therapy, pancreas and stomach, alcohol-related, colon, low fiber, high-fat diet, Western diet. Advances in technologies. These are the choices we oftentimes face. Ventilators, gastrostomy tubes, which are surgical openings that are made in your abdomen straight to your stomach, and it's a tube that you live with. And you fill, or your family, or your care provider fills with nutrition. Dialysis is a choice we may get to make. We recently have had the advent of implantable cardiac defibrillators and ventricular assist device to keep things beating. Most of us are going to die of what I call the dwindles. Okay, we're not going to die, most of the time we don't die of a sudden cardiac event or a sudden stroke. Most of the time we're given warning that we are on the end stages of our lives. And I'll give you an example of the type of patient that I oftentimes deal with. Okay, you've been desk-bound your whole life. Exercise has not been a priority. So have you spent your life watching football instead of playing football? You smoke, you have a poor diet. Oh God, you become overweight and obese. It sort of catches up with you. Because of the obesity and lack of exercise, you develop arthritis in your knees. And again, back ruptured disc is oftentimes related to weight. Your body just can't handle the weight. So now you can't exercise even if you wanted to. You become diabetic, hypertension, and because you smoke, you develop lung disease. Well, then you have a stroke because of the hypertension and the diabetes. And now you're paralyzed on one side, and you can barely walk, and now your spouse is having to help you or care for you. You're too big to care for. You've got this little wife who just can't get you out of a chair, and you become a strain on your family. So you become straddle-lounger bound and bed-bound, and that becomes your world. And because of your lung disease, now you're on oxygen, so now you've got this tube carrying around. So all the smoking, the diabetes, the high blood pressure, and now you're isolated because the only person in your life is your spouse. Now you've got Alzheimer's, because all of those are risk factors for developing Alzheimer's. So because you're inactive, and you're straddle-lounger bound, oh, you're inactive, and you're just not able to clear your airway, and you end up with pneumonia, and you're in the hospital. And because of your lung disease, now you get to choose, do you want to be on a ventilator to prolong your life? Okay, you're in the hospital, you got pneumonia, you're on the ventilator, and your diabetes causes your kidneys to fail. And again, you have a decision. Do I want dialysis? So you're lying in the hospital, you're not moving a whole heck of a lot, you develop a blood clot and you stroke out. And you end up in what they call minimum conscious state. You end up having to make the decision, now do I want a feeding tube? You'll notice at 3 junctures, you've had a choice as to whether or not you want those procedures and whether or not you want to enact your advance directives. Okay, everyone was born with the right to die, the right to life. What about the right to die? Should any law upholding a person's right to life should inherently include the right to die? So let's talk about the court cases where it started. Karen Ann Quinlan, you all might remember, 1975. She was 21, she had an overdose of alcohol and 2 prescriptions. She stopped breathing for 15 minutes and she became in a vegetative state and on a ventilator. This was a very pivotal point in the court cases. Parents wanted removal, the hospital fought, the doctor fought. Over protracted court proceedings, the tube was removed, the ventilator tube, but she lived for almost another decade. And she, of course, had that gastrostomy tube in her stomach that kept her alive. Okay, the 2 significant outcomes of her case is it developed a formal ethics committee in hospitals, nursing homes, and hospices, and the development of advanced directives. Next one was Nancy Cruzen. She had a motor vehicle accident and left her in a persistent vegetative state. Her family petitioned the courts for 3 years, got to the Supreme Court, and she eventually had her feeding tube removed. So now we're going down the food chain. She wasn't on a ventilator, that she had a G-tube. G-tube is gastrostomy, so if I use that jargon. The court initially denied the family's request because they said they didn't have any evidence of Cruzen's wishes. They stated that she hadn't documented it or that there was not enough verbal evidence. It went to the U.S. Supreme Court. It was ultimately granted because they found evidence that, I don't know what kind, I believe it probably was verbal with enough people, saying, yeah, she's mentioned it. And then she died, G-tube was removed and she died 12 days later. So the courts recognized for the first time the constitutional right to refuse treatment. It spurred interest in living wills, which clearly expresses the individual's desire to discontinue treatment or feeding in specified circumstances. Terry Schiavo, we all remember that one. That was huge. She collapsed in her home, full cardiac arrest. She suffered massive brain damage due to lack of oxygen and eventually was diagnosed as being in a persistent vegetative state. These pictures are what, the first one is, this is the progression of events when your heart stops. The first one is ventricular tachycardia, then it gets really fine, and then you go into straight lining, which is when your heart completely stops. On the left is a normal CAT scan. Terry's CAT scan on the right, you can see that all that black area is just fluid-filled area. The legal battle, her husband wanted her to discontinue her G-tube, but you can see how long that lasted, the court case. Lack of a living will caused her to continue. Lack of a living will caused a protracted series of appeals to determine what Terry's wishes would have been if she wanted life-prolonging procedures. Keeping Terry alive became the focal point for the Right to Life movement. As you can see, there were multiple legal bodies that were involved. That's why I put send in the clowns. At issue as to whether or not the husband had the right to make decisions versus her parents, who believed, since Terry was making some vocalizations in response to stimuli, they decided that there is some help, there is some light inside. Anyway, finally, after 7 years, her life support was terminated. Okay. They said that she had made reliable oral declarations that she would not want life support in this situation. So, what happened? Self-Determination Act requires that healthcare institutions receiving Medicare or Medicaid, which is going to be everyone in that business, anyone having those type of reimbursements, provide patients with written information about advance directives when you enter their institutions. Important thing about the Self-Determination Act is they actually encourage patients to make preferences for end of life before the crisis, before you really need it. So you can make sane, rational, decisions about what you would like without that pressure. It is derived from the principle that an adult has the right to decide what happens to his or her body. It documents the wish of the person to give directions about future medical care, or designate another person to make those decisions for them, should they not have the capacity to make them. It also mandates that healthcare providers document this in your chart. A patient's right to make decisions in advance directive is now protected by federal and state law. Who has advance directives? Not a whole lot of us. 14% of Americans have written advance directives. A low percentage has significant implications for the aging population as well, for younger adults who oftentimes don't think about the need for advance directives until they're confronted with a life-threatening medical diagnosis. Living wills and other advance directives aren't just for adults. Unexpected life situations can happen at any age. So it's important for all adults to have advance directives. Think about the #1 cause of death for younger people is accidents. So you end up in a motor vehicle accident and you're in a vegetative state, and now what? Your parents get to decide? You end up in a situation where, again, the parents are going to have to say, okay, yes, this person said no life support, or make those decisions. It's much harder when you have a younger person who has a greater chance of recovery. Everyone over 18 needs an advance directives, and as I said, younger people generally don't consider the need for an advance directives. Not considering death imminent, the group, they are known for risky behavior, rock climbing, yet the main causes of death can lead to brain damage and death and inability to make advance directives decisions. Okay? Leading cause of deaths for younger people, accidents, homicide, and suicide. People over 65 whose heart stops outside the hospital setting have a 2% chance of survival. Of those who survive, half will end up permanently in a nursing home. Only 1% will return home. I wish I had a nickel for every 80-year-old whose chart I look at, who's a full core. That means full resuscitation. 50% of Medicare funds are exhausted caring for patients in the last 6 months of life. So let's look at Medicare. Do we want to put our resources into people who are generally healthy, older people, or do we want to encourage people to sort of deal with the end-of-life issues and say enough? The sickest 1% utilize 30% of allocated Medicare funds, and the top 10% consume 80% of those funds. That's where Medicare's funds are going. When most people want to die at home, most of us will die in a nursing home or a hospital. I have a fabulous friend whose father-in-law actually was very healthy, 86-year-old, walked 6 miles a day, played tennis 3 times a week. He jaywalked and hit by a car. Initial injuries were a thigh fracture, rib fractures, closed head injury, and a punctured lung. He was on the ventilator. He had a stroke. He went into kidney and liver failure, developed pneumonia. He was placed on antibiotics. He had a horrible reaction, and his skin began to slough. The doctors considered putting him on dialysis. He had no medical power of attorney. Okay, the family argued about what to do, and 3 months, and $1 million later, he finally died on his own. Okay, so you have defining events. Some of them are acute, like my friend's father-in-law. Something happened, there was a defining event, and you had to make a decision about where to go. So stroke, heart attack, motor vehicle accident. I put lung disease in there because sometimes, again, with that pneumonia patient, you decide, okay, ventilator, no ventilator. Sepsis, which is massive infection, again, that causes your blood pressure to go down tremendously, and that is an acute event. And of course, brain injury. Chronic things are, again, there's no sudden event. It's a dwindle. We talked about the dwindles. At what point do you decide, I'm done? It's time to do comfort measures, it's time for hospice, it's time for palliative care. Dementia and Alzheimer's disease is an unbelievable taxation on our system. If you're 85 or older, there's a 50% chance you're going to have dementia. Global geriatric decline, debility is a very common, that's a dwindle. Weight loss, frailty, inability to perform basic things, dressing, bathing, you're relying on somebody else. Again, cancer, neurologic disease, autoimmune disease, those are dwindles. Okay? Congestive heart failure, lung disease, heart disease. Let's talk about vegetative states because that adds to the confusion. The vegetative state is a rare condition caused by brain damage where a person is in a coma but may be fully awake because they have no sense of awareness. There's a lot of people per year that end up in that state. They end up with it because of traumatic brain injury, car accidents, or a fall, like my friend's father-in-law, or stepfather, or non-traumatic, caused by a stroke, caused by Alzheimer's disease. 40% are diagnosed with mentally conscious state. There's a thing called a locked-in syndrome, where a person is fully aware but unable to move their muscles and are unable to speak. There is a French author who actually dictated an entire novel blinking their eyes. You may not be able to speak, blind, deaf, epileptic, paralyzed, and unlike a persistent vegetative state, people with minimum conscious state have partial preservation of consciousness. They can squeeze hands, they can follow an object with their eyes. The consciousness comes and goes. Occasionally, they will awaken to some degree. So you decide, okay, what do I want? What is recovery? Is recovery being able to look around the room? Is recovery able to cry when I talk or perceive when a family member is holding my hand? Or is it talking, walking? You get to decide. What level of functioning is sufficient for you to continue? Patients over 40, under the age of 20 have a 1 in 5 chance of making a recovery. Over 40 is almost non-existent. People who do recover oftentimes have lifelong physical and mental disabilities. So you get to decide. Both of those conditions require a feeding tube. So again, you get to make a decision. How important is it for you to be independent and self-sufficient? What would make your life not worth living? Would you want treatment to extend life in any situation? What would you want treatment only if a cure was possible? Do you have a goal in mind that influences your decision about extending your life? Some people, some cancer patients, they are terminal, but they decide they're going to go through chemo, they're going to go through radiation because they really want to see their granddaughter get married. That is a legitimate choice. Yeah, I want to stick around, I'd like to watch. Do you want palliative care hospice for comfort measures if you were terminally ill? Resuscitation, that basically means restarting your heart through electric means and then medication if your heart were to stop, and also artificial respirations and breathing, which may include putting a tube down into your lungs and into your and help other people help you breathe. Once you get to the hospital, there's cardiac assist device, like a balloon pump that actually functions as a ventricle. Then you get to decide, mechanical ventilation. Great, you're in the hospital, they're bagging you with the bag, to get you to breathe. Do you want to continue? It takes over your breathing, and do you want to be on a mechanical ventilator? That's what it looks like, it's not pretty. Do you want a gastrostomy tube? You can have a tube that, again, goes into your stomach, and you get to decide how long you want it. Maybe you think, well, maybe I am going to recover. Do I want that G-tube in for a week, 2 weeks, a month, a year? You can also have temporarily, you can have artificial nutrition through an IV. It's called TPN, or total parenteral nutrition. It goes into a vein in your clavicle, and again, you can be on that for several weeks to months, but eventually you have to make a decision. Do you want that too? Okay. Dialysis removes waste from your bloodstream because your kidneys are no longer functioning or reduced. Again, you get to determine, how long do I want this? As with all the other things we decided, we discussed, it's fairly quick death. Once you stop dialysis, it's a week, 2 weeks, 3 weeks, your waste products do collect and that you do die. Realize if you're on dialysis, it is quite a commitment, 3 times a week for 4 to 6 hours at a facility. Other interventions, pericardial tap if you have fluid on your heart, paracentesis, fluid in your stomach, along the peritoneum in your stomach, thoracentesis, fluid in your lungs, which is real common among cancer patients, and surgery. What do you want, comfort versus treatment? Emergency care, do you want to be hospitalized for further interventions? Antibiotics, if you get pneumonia, if you get septic with a blood poisoning. Do you want to wish to be comfortable in your own home in your last days? Hospice and palliative care may be better choices. The most important asset you have is a physician who can tell you realistically what are the outcomes. Somebody who is not interested in prolonging life to cover themselves medically, to push unrealistic interventions. Someone who can be trusted. Okay, let's do an example of lung disease. It can be treated, but it can't be cured. It will get worse over time. You get pneumonia a lot, repeat hospitalizations, you may end up oxygen dependent, your quality of life goes down, and you have to consider, what is it like to be intubated? What is it like to be air hungry? Those are conversations you need to have in advance with your physician, so when the time comes, you're very clear on what you want. What are your thoughts about dying? Do you want to avoid pain at all costs, or do you want to be awake and alert? What kind of a quality of life is acceptable, and again, what are your goals? Let's start with choosing a medical power of attorney, probably the most important decision that you will make. That is somebody who will basically make decisions for you in the event that you cannot make decisions on your own. It's different from a fiduciary or a POA, power of attorney, who makes financial decisions. You usually don't want that person to be the same person as your medical power of attorney. Trust is absolutely important. You want to choose a medical power of attorney who will reflect your wishes and not interject their own opinions and values. Okay, so you really want to pick somebody who's on the same page that you are. You want to pick somebody who's confident. You don't want to pick somebody who's kind of, oh, I don't know if I, you know. You want somebody who will listen, who's adult enough and mature enough to be able to say, yep, this is their wish, and this is what I'm going to. It's not about what the power of attorney wants. You want, like I said, it's probably the most important decision that you will make. Okay? Don't choose someone because if you feel guilty or obligation. Well, you know, my brother Bob, we've always been close. No, you know, he's got a different value system than I do, but he'll feel really bad if I don't choose him. Wrong. Okay? It doesn't have to be a family member. As I said, you want somebody to be different than the person who does your finances in general. And it's helpful to have somebody who's in the same city, because oftentimes these decisions are immediate decisions. And involve your family. They might not agree with you, but they need to know what your values are. They need to know who your medical power of attorney is. Who is an incapacitated adult? Who is a person who is unable to effectively receive or evaluate information, or both, or communicate their decisions. Okay? They lack the ability to satisfy the essential requirements for physical health, safety, self-care, even when appropriate and reasonably available with technological assistance. This is the legal term. Okay, don't you love the Messiah? What happens if you don't have a medical power of attorney? Well, you can get a bunch of interested parties like these guys who are meeting in the savannah to get together and choose one of the group to be a proxy decision maker. And you can actually have a form online, as you can see, to fill out. And it acts as a legal medical power of attorney since there's been a sort of a committee. Do not resuscitate order. This is basically in the event that your heart stops, no artificial breathing, no electricity, no pumping of the chest, no medication will be performed. It is a legal, binding physician order, and it never expires. It should be in your medical chart. It should go where you go. Let's see. Advance directives do not have to include a do not resuscitate order. You can leave that up to the medical power of attorney, but they will resuscitate you if you don't have a do not resuscitate order. Okay. Where can you put this? How do you let people know that you are not resuscitatable? In the back I have file of lives, which are those red things. Those are magnets that you put, enjoy, take them. You put them on your refrigerator. The first place paramedics look when they have a core situation at a home, they look on the fridge. Do you have an envelope with your DNR? In that file of life, it's red, it's a magnet, it says, hi, howdy. So they will go ahead and look for it. ID bracelet or necklace is a good idea. Again, you're at the Safeway. and you're down. They will look for a bracelet. They will look for a necklace. It's also a good idea to have if you have a seizure disorder, diabetes, or any kind of chronic disease that may cause you to suddenly pass out. You can have documentation on your person, but I'll tell you what, the paramedics are not going to rifle through your wallet while you're crying. They're not going to look for that DNR. You know, the hospital might eventually look for it after they've stabilized you. But again, the DNR doesn't help once they've stabilized you and you know, you're on your way to the intensive care. In this situation, a person is choosing a tattoo. I like that. In the hospital setting, is honor documentation readily available, and you can, in hospital setting, everybody should be asked about their course status, and is readily available for them to find in the event that you do go down in the hospital setting. The validity of a do not resuscitate and the identity of a patient need to be confirmed. Otherwise, the paramedics will go ahead and perform CPR. Advantages, at home the paramedics often follow if documentation is readily available. It is ultimately it's up to their discretion. Deficits, it's only about your heart and breathing stopping. It does not include a medical power of attorney. It does not include any advanced directives like tubes and things like that. In the field, it rarely gets followed in a sense unless you have that ID on you. They'll go ahead and core you. Okay, living wills, written legal documentation that spells out the type of treatments and life-sustaining measures you want and don't want, such as respirations, ventilation, tube feedings, or, like I said, resuscitation in the event that you're incapacitated. It is not a physician order. It is more of a suggestion. It's a directive. In other words, this is the course I want to take. It has a lot of fudge room to it. It needs a medical power of attorney to enact your wishes, which is where that trust comes in. Advantages, it's short and sweet. It gives specific time parameters as to far as how long do I want that gastrostomy tube in, how long do I want to be on the ventilator. It can be strictly interpreted, but is mostly up to the medical power of attorney. It's not very detailed. It does not contain a do not resuscitate, and it almost never happens. The medical power of attorney usually steps in. Now, I provided a whole bunch of documentation in the back. There are living wills available. All the documentation can be copied, and if you have friends who want it, that's great. 5 wishes, you guys might have heard about those. It's more about, it's about healthcare decisions, living will stuff, but it's also about, you know, how do I want my body be treated? You know, what kind of medical treatment I want and don't want, how comfortable do I want to be? Who do I want to be my medical power of attorney? I did that out of order, sorry. How do I want people to treat me? Do I want to be at home? Do I want people to pray at the bedside? What I want my loved ones to know about forgiveness, how you want to be remembered, final wishes, funeral plans, memorial plans. It's kind of nice. Advantages is it's comprehensive. It contains a place for medical power of attorney. It's a bit long. And as with a living will, it is a guide for the medical power of attorney, and it does cost money. My healthcare decisions, I really like that. There's, again, copies of it in the back. Again, it's pretty comprehensive. What do I want to know about my condition? Is it terminal? What's the situation? Do I want a strict interpretation of my healthcare decisions, or just sort of interpretation? Where do I want to die? What quality of life do I want? What are my treatment options? It just covers spirituality, organ donation, and the treatment of my body after my death. The document. Just a minute, please. Un momento. Oh, come on now. Okay, that's what it looks like. Okay, and again, there's everything, all kinds of copies of these, flip through too fast, are available in the back. I really like this one. You can see that it gives you lots of choices as to how you would like to proceed. Okay, advantages. You can add a narrative. It's comprehensive and it asks really smart questions. The deficits. Again, you do need to assign a medical power of attorney separately, so that would be a living will. And it does not contain a do not resuscitate order. The most form is great. It does not need a medical power of attorney to consult and enact. It is your wishes. It is a legal, binding medical doctor order. The medical power of attorney cannot countermandate that wish. It covers resuscitation status, comfort measures, medical interventions, whether you want full, limited, or comfort. It covers antibiotic use, use of IV therapy, and tube feeding with the gastrostomy tube, as I said. Basically, like I said, it contains a do not resuscitate, level of interventions, and artificial nutrition and antibiotics. Advantages, it is a medical doctor order. Okay, it cannot be countermanded. Okay, comfort measures are never optional. It's more comprehensive than the DNR. And it's not flexible. The deficits is not flexible. You know, it's an order. You can't, you know, the medical power of attorney can't, you know, countermand it. All advancce directives document can be rescinded at any time. All advancce directives can be rescinded by yourself at any time. And I'm sorry you can't really see this, but basically it says the do not resuscitate in the most form are legally binding. Living will, 5 wishes, and healthcare decisions are at the discretion of the medical power of attorney. Living will and 5 wishes contain a medical power of attorney designation. On the most form and the DNR, we do suggest a bracelet, and all copies of this are valid. I'm sorry, I really tried to make this easier. Do you need which forms? Okay, which one do you need? The most important is the medical power of attorney. DNR or most form if you're really defined as to how you want to proceed. Do you want resuscitation and then have medical power of attorney make those decisions? Most end-of-life decisions will be made by your medical power of attorney. Problems? Your medical power of attorney decides to countermand your wishes. Disagreements in your family, they're arguing with the medical power of attorney. And here's an example a physician gave me. You have a 23-year-old, sees granddad dying on a ventilator, and impulsively decides to act by composing a DNR or most form. Well, again, that's kind of creepy. You know, they have a fairly good chance of being resuscitated if they go down in the field. For one, most 23-year-olds don't die of a heart attack or a heart problem. It's usually a breathing issue. And they are resuscitatable, but you don't want that impulsivity. You do have an option under the Healthcare Affordability Act to have 1 visit free with your physician to discuss advanced directives. Once you fill out the forms, give one to everybody in your life, I swear. Copies to your doctor, your medical power of attorney, family members. Put it in a safe, give it to your lawyer. And also you want to keep a card in your wallet that says you have a willing living will and where it can be found. I love Marcus Welby. Barriers, time constraints, reluctance, assumptions about medical treatment, denial, that's a big one. The 80-year-old who's a full core. Unrealistic expectations, again, 80-year-old who's a full core. Delaying until you get a crisis. Discomfort with the end-of-life decisions, palliative care planning, lack of documentation of medical orders, cultural differences, lack of knowledge about the Patient Self-Determination Act. Okay? Other obstacles, even when patients have advanced directives, they are oftentimes vague and incomplete or disregarded. Family members can't agree on what to be done. Oftentimes physicians and hospitals have an impetus to do the most aggressive treatment even though it's not in the best interest of the patient. Deciding to curtail treatment in a critical care process produces unique problems because you're making an impulsive decision. Most patients and families don't have any experience with critical care and end-of-life decisions, so again, you're pressured. It may be difficult to convince some family members that the aim of withholding is to alleviate suffering. Okay? Durable medical power of attorney. This is advanced directives that's not related to health. It's about executing legal documents that can provide power of attorney to others in the case of incapacitated medical decisions. It allows people to make bank transitions, sign social security checks, disability. You're basically acting for an incapacitated adult in a fiduciary setting. Guardianship. I am faced with that all the time with patients who don't have a medical power of attorney and they do become incapacitated, and they're not on a ventilator, they're not in a G-tube, they're at home, they're living, but they're not functional. We talked about what the definition of incapacitation is. Guardianship is a court-ordered position that's usually given to a non-family member, and it is supposed to be have that person make decisions that are in the best interest of that patient. Dolores. This is a true story. She had no advance directives of medical, financial, power of attorney. She lived in a small little cracker house in Longmont, which was filthy. The son actually said she never cleans her house. Her refrigerator was a science experiment. She had 2 dogs. One of them had a neurologic disorder. They were both really old. She never took them out of the house. Imagine the smell. She actually, because this one had a neurologic disorder, she went vet shopping in Longmont. And every single vet said, we got to put this animal down. And she didn't like the choices, and so she went to the next vet. Finally, the vets were really funny. They emailed each other and said, beware, this lady's vet shopping. She had significant dementia, as you can imagine. She drove. She was still driving. She was found in a ditch in Kansas by some hunters. She had injured her hip, and she was brought back to Boulder. She refused to stop driving. She refused to do anything. Nobody had decision-making capacity. Okay, I ended up calling Adult Protective Services, who did get involved as best as they could. The next thing you know, oh, wait a minute. Between that, the son said, okay, I'm taking away the keys. I'm taking away the car. We're going to find transportation, alternative transportation for you. He took the car. 2 days later, she had in her driveway, same make, same model, same color. Okay, she went out and bought another one. She was found in Wyoming, 100 miles off the interstate, walking in the opposite direction. She had run out of gas. State Patrol picked her up, took her to the ER. She was fighting them. She was disoriented and cooperative. She was brought down to Boulder, finally, where she went out driving again. And she was found by the Boulder police with erratic driving, put in the jail for a few hours, went to Boulder Community Hospital, where she was finally transferred to a geropsych unit and was placed in a memory care unit, locked, okay, where she lives now. But the son had to get legal guardianship. If she had had a medical power of attorney, she was incapacitated, and he would have had to, most of this didn't have to happen. That is a real case. It was unbelievable. Conservatorship is about a different level. It's about finances, people who are elderly who have been scammed, managing finances, property for an adult who is incapacitated, assets, charities. They're little old people. They're dement. They're going to go ahead and they're writing checks for $5,000 to the Heart Association, you know. And meantime, they're spending all of their savings. A lot of people scamming. Okay. It's different than a medical power of attorney in that this is after the fact and it is court ordered. And I'm sorry about this. I'm going to fly through that. You can't read it. Organ donation. You can specify in your advance directives about donating your organs. I can come back to later on if you want to see the email to how to go ahead and do organ donation. People think, oh, I'm 85. They're not going to want any of my body parts. Well, you're wrong. There are things that people can, have harvested from their bodies. Corneas are the easiest because there's no rejection. They don't have blood going to them. They're sort of what they call avascular, and people can have those be used. So you never say never. You can put it on your driver's license, state ID when you apply for it. And again, let your medical power of attorney know what you want. These are the organ tissues that can be donated. Okay, lots of them. If you want to donate your whole body, won't you love these? Have you ever been to these plasticized things over at the museum? Oh my God, a fabulous exhibit. Anyway, that's it, and I can go back to that later. Here's some website resources. Again, I'll flip through that. Growing old is not for sissies. Take care of your bodies. Take care of your bodies. And anybody who is a fan of Hitchhiker's Guide to the Galaxy, part of what they decide they're looking for is what is the meaning of life? And throughout this entire book, they come to the meaning of life, which was 42. No, I can't figure it out either, and neither could they. I don't know. I know. I don't get it either, as it says. So I'm going to leave you on a more positive note. I am not somebody who evangelizes or proselytizes. Just ask my friends. But a few years ago, it was actually my 13-year-old son who introduced me to a fabulous book. It impacted my life in a tremendous way. And I'm going to share it with you. And no, I'm not getting paid for this. 5 secrets you must discover before you die. John Izzo is a minister, but this is not a religious book by any stretch. He went ahead and asked, what must we discover before we die? What do those at the end of their lives have to teach us? Why do some people find the meaning and die happy? What does it mean to live a full and meaningful life? 5 secrets. You've got to read the book. Be true to yourself. Am I following my heart? Am I focused on things that really matter to me? Am I being the person I want to be and not anybody else? Leave no regrets. Constantly asking, when I get old and ready to die, will I regret the step I'm about to make? Become love. Love yourself and treat others with kindness. It's the golden rule. Live in the moment. Very Buddhist. It was very relevant to everybody. Since I read this book, I can't now tell you how much I appreciate my life. So much more. Every evening before I sleep, I try to count 3 things that I'm appreciative of. It's my 18-year-old, now 18-year-old son is always on the top. Having my health, having my job. Give more than you can take. Make the world a better place. Leaving a legacy will make those final moments in your life so much richer. Live long and prosper. Hope it's a very long time. Questions, comments, or for really a fabulous green chili recipe? That's it.
Thank you.
Questions? Hopefully I can answer them. Yeah?
If you appoint a medical power of attorney, can you also appoint a successive medical power?
Absolutely.
And in addition to that, does the person that you appoint must be over 21 or can you
I think it's 18. The question was, can you, if your first medical power of attorney can't function in the capacity, can you assign a successor? The answer is absolutely. Most forms do allow for you to assign a successor. My medical power of attorney is I have a brother who is an ophthalmologic surgeon, so it's a no-brainer for him to be able to. And I've actually been very communicative about it. For example, I mean, however radical this sounds, if I'm a quad Even if I'm upstairs, I don't want it. I don't want to live like that. That is my decision, and I've communicated that.
About the age,
Oh, I think it's 18. Your legal age. I'm pretty sure it is.
you can appoint, I mean, that's the person who appoints your grandson or daughter.
Absolutely. But I would generally suggest somebody who's more mature, unless you've got a really mature 18-year-old. And I love my son, but he ain't it. Yes?
I belong to Kaiser, and now there are things on the computer. I remember getting my advanced directives and everything.
Uh-huh.
How is that transferred to the hospital? I understand that my doctor doesn't go with me to the hospital. It's a hospitalist now or something. How do they, Kaiser specifically?
Okay, specifically within the Kaiser system, and I'm only talking about the Kaiser system, excuse me, they have a fabulous computer medical record. It's in your medical record at Kaiser. They can see it at least the Kaiser facilities, at Good Sam, for example.
That's the second question.
Yeah.
They told me in a real emergency I would be brought to Boulder.
That's correct.
Rock Creek. So what happens?
Boulder Community Hospital would not have a copy, so they'll go ahead and resuscitate you and get a hold of a family member and say, okay, medical power of attorney, who is it? You know, so.
In other words, there is that time in between.
Yeah.
Carrying a DNR with you.
Bracelet, tattoo, in your pocket. Okay, yeah, you had a question. Sir.
What important points could you make about the role of us handling, doing something with Medicare at the end of life? That was the title of your talk, and I missed the Medicare.
Oh, well, the Medicare part was very brief, and the thing that I was trying to emphasize about Medicare, I have a strong opinion about how Medicare funds are being used. There's an enormous amount of waste. Some of it has to do with providing care for the last 6 months of life, and again, that's that one affordability healthcare decision-making visit you get for free with now, the death panels, remember that? With your physician to compose this, to discuss your values and your goals in advance of needing it.
And Medicare pays for it.
Absolutely. It is now free. And it'll be in your chart, hopefully in your pocket. All of these forms are transferable from agency to agency. But you've got to have it on your body. And one of the things, and I'll say this, part of my job as a senior care coordinator, for example, we're talking about Medicare waste. I call patients within 24 to 48 hours after they've been hospitalized. How are you doing? Are you taking your medications correctly? I go through the list. Are you pooping? You have no idea how many people end up in the ER because they're plugged. Okay? Are you eating and drinking? Who's caring for you? Okay? And then I make sure that you have a follow-up appointment with your physician ASAP, 3 to 5 days. Just that measure alone has reduced hospitalizations, and I'm not supposed to give you numbers, so I won't. But the average rate of 30-day rehospitalization among Medicare people is 20 to 25%. We have less than half of that. Think of the money. And there's actually we're giving better care. So I see a huge role for people, nurses, in my role, in the future. I have job security in a big way. Aging population and Medicare costs that need to be reduced. And you're going to see senior care coordinators, RNs, in this role becoming more involved. I personally believe, my own personal thing, is that Medicare will mandate this, even with private pay physicians. All systems are going to have this. So, anyway, there was some. Yes, please. Yes.
So, hopefully I can speak loud so you can hear.
Go ahead.
In the last year, I've lost both my mother and my father. I had them both in hospice.
Yes.
And I had to fight to get them in hospice. They did not have, that clear diagnosis, you're going to die in 6 months.
Sure.
My mother was a dwindle. Spinalolisthesis. Hypertension. She took about 16 medications a day. So I had to say, to the doctor, no more 911.
Sure.
And the palliative care I knew about because I had buried my husband a couple years before from bone marrow transplant. So you can ask, when you say Medicare, you can ask for palliative care for your elderly parent. And all you need is a doctor to write the order for it. And what it does is it gets you out of 911, hospital, nursing home, right?
The revolving door.
Home care, 911. And what is it for? A urinary tract infection.
Yeah,
right?
that could devastate
Pneumonia.
somebody. Sure.
All these sort of, now my father, he had a little bit different, he had dementia and he had cancer. He did not have a terminal diagnosis with his cancer, he had multiple myeloma. But the doctor wrote the order. And we got out of that cycle. And I think that's the most important thing for people to take home and understand. There are two ways you can use Medicare. You can use it for palliative care, and you get a nice team that helps take care of your parent or your elderly aunt or uncle or whatever, that you don't have to go through this 911. You can call the hospice people. You can keep them very, very comfortable, and they can die of, you know, what used to be called natural causes, even though they don't have a terminal disease. And I think that's really important to know.
Yeah, let me just explain, thank you, that's fabulous, the difference between hospice and palliative care. Hospice is for patients who hypothetically have 6 months or less. It is comfort care. You do not have to be homebound, so you can go on your cruise for one last time. They usually have a nursing assistant, an RN, a chaplain, a social worker. If you do it through Boulder Broomfield Hospice, you get somebody who'll chant for you and bring a companion dog and aromatherapy. Anyway, and I love them. I love the Boulder Broomfield. I'm sorry, I'm pulling in a plug for them too. I'm not getting paid.
I'm family hospice. So.
I'm sorry, but anyway, but you're right. It's a really good program. The difference between that and palliative care is for patients who are homebound. They still want aggressive treatment. They might have a cancer that will eventually terminate their lives, but they still want chemotherapy. They still want dialysis. And the question is will these patients still be alive in 2 years? If the answer is no, then palliative care is usually a very good option for you. And again, you get all of this through your physician. Okay. Now, I don't know the stats, but I believe the average hospice. Now, you can have at 6 months, if you're still alive, hospice will reevaluate you and most likely recertify you. They're not going to say you're not dead yet. I'm sorry. So they probably will recertify you. But the average length of time someone spends in hospice is 14 days. Okay.
Because people wait too long.
People wait too long. Okay. Now, I personally give out hospice referrals and palliative care referrals like candy. Hospice will go in. They have their guidelines. It's paid for by Medicare. It is free. Palliative care is free. And they have a doctor coming to your home on both situations. Let hospice decide. Most physicians do not know what hospice and palliative care criteria is. Refer them.
Right.
Let them decide. It's their organization. If they don't if the patient doesn't follow criteria, they ain't getting paid. So you can believe me, they're going to make sure you follow their criteria. Yes, ma'am.
I was wondering how HIPAA privacy forms work with your durable medical power of attorney if you haven't put that person on your HIPAA form.
It's medical power of attorney supersedes any HIPAA.
Okay.
There's an implied HIPAA there.
So there's no problem.
Yeah.
Okay.
Yes, ma'am.
Yeah, I've been trying to get straight on what Kaiser does with something called continuing care, which is supposed to be for dwindlers like me.
Right.
Yeah, I'm a dwindler.
Okay.
And there's no question in my mind. And I don't qualify for hospice, I don't think.
No, probably not. Not if you're here.
I think I qualify for that program, which I'm paying for, which I understand gets me 15 home visits.
Right.
And so where do you go to talk to the people to see if that's a possibility?
Your own physician. And they do have criteria. Again, this is a Kaiser special thing. I'm sorry. I am not representing Kaiser, please.
No, but I'm sure.
But you do
some
have a
other
Kaiser
plans have
question.
something comparable, don't
Talk
they?
to your doctor.
So the endpoint to all of this stuff is your doctor.
Absolutely. And the whole thing with, and I'm speaking specifically to this program, is you have to be, usually have to be homebound. So if you're here, you probably wouldn't qualify. So, yes?
I don't know if this is a problem. I mean, Kaiser, wherever you are, has your record. That's great. But for those of us who are not Kaiser, we
Yes.
have our GP, who we talk with. Then we go to the hospital, and it's completely different staff.
Yeah.
Is there a problem there at all?
Well, you know, again, there is a push federally to have a universal electronic medical record. It will save so much money.
Agreed.
It has your allergies, it has your history. It'll have your do not resuscitate in your most form.
But it isn't there now.
I wish I had a magic wand.
Will the election change that?
I am so not going there.
Well,
Yeah, sir.
If you've expressed your wishes and the appropriate documents to have your body donated to science when
Yes,
you
sir.
pass away, but you haven't specified anybody in particular, what are you doing with it?
If you have a medical power of attorney, they'll decide.
Well, what if that person, I mean, what if you don't have one? I'm just curious, is when there isn't anything that's specified other than donate to science, which scientist shows up to take you?
You know, I don't have an answer for that.
That's really not enough. In Colorado, if you're going to give your body to the Colorado anatomical group that coordinates all that, you have to make that arrangement before you die.
There you are.
And if you don't,
they won't take your body. Sorry.
Even with a medical power of attorney who says, go like this.
Rejected.
Thank you for clarifying that. Couple ladies? I need, give me the 5 minute, okay? Yeah.
I just wonder what most means exactly. I mean, is it MOST? Does that represent something?
We're going to find out. This should be, do you guys have a most term or should be on the top there?
we just told you about this.
Okay, what is it?
Medical order for sustaining treatment.
Thank you.
Thank you.
I would say most. Medical
Order
order
of sustained
treatment. There you are. Scope of
Yes, I was
treatment.
wrong.
Thank you. Yes, ma'am.
The one thing I wish they would do with the most forms is say to an elderly patient how successful they are when they resuscitate people who are 80 years old.
Right.
I would love but it seems like they don't want to add anything.
No.
You know, like my father's like, well, what does that mean? You know, you won't resuscitate. And I actually made the doctor go into how often it really helps. It's usually not good in terms of the outcome.
1% chance you're going to return home,
It's
and even then you have no idea what it's going to look
But
like.
everybody thinks it's like, oh, no big deal, we get resuscitated, you know, and I really wish they would say more about, I almost feel like you should request to be resuscitated rather than have a DNR.
Right.
It's really so dangerous to an elderly.
Well, you know, having done CPR on older people, it is that first time, and I don't want to be graphic, but the first time you do the chest compression, you're breaking every single rib, and you can hear it. It's just nasty.
So listen to that, right?
Yeah, and exactly. And a lot of doctors are very reticent about being straight with patients. And I do want to say that, you know, I've been around the block long enough. Being a senior care coordinator has been not only a profound professional experience, but personal experience. And what I have found, and this relates to the 5 secrets, there are patients I have dealt with who, they're 85, they have terminal cancer. They want everything. They want to live, they just want everything. And they don't have that goal in mind. They're just not ready. They have had 85 years to deal, and they're just not ready yet emotionally. They're afraid. And everybody's got a fear of that kind of thing. You know, you have to deal. But I have had patients who I've talked with, and they're so, I'm okay. They're so graceful. They're so accepting. And those are the people I'm finding out that are living the 5 secrets. They've dealt with their lives. They feel good about what they've done. They continue to do good things. They usually have very close families. And they're dying so gracefully. And they deal, and I just love my patients who are like that. I truly have felt inspired by them because they're just fabulous. Yes, sir.
I was confused by one of your personal comments.
Yes, sir.
You said if you were a quadriplegic and you were all right up
It's
here.
just me. It's my personal
Just a moment.
choice.
You were
Yeah.
all right up here.
Yeah.
None of what you said today would apply. Is that correct?
No, it's a personal preference that I have voiced to my brother.
No, I mean, as long as you can make that decision, none of what you said today is operative.
Well, if I'm on a ventilator, because
You're not. You were simply a quadriplegic.
Oh, I'm sorry. I should temper that.
About that?
I would not, say if I was in a situation where I was in a ventilator and I was not able to verbalize that it was time. That decision would be left to my medical.
And you're paralyzed, you can't indicate in any way, that's the point.
No, no. And you take a look at, was it Christopher Reeves? He was on a ventilator.
But he was perfectly competent to indicate.
Exactly. No, I understand that. It's just, it depends on the level of disability, and so
My
I just...
point is, none of this was operative here, as long as you're capable to make a
Yeah,
decision.
I mean, no, I agree with you. Yeah, if I'm here, if I'm present, and I'm able to make that decision. But, you know, if I was not, and I was not able to quite communicate that, I've made it very clear as to what my wishes are. And it's personal, it's just me, it's what I want. Yeah.
I guess, Janice, that's a really good question, because
Yeah.
at what point does any of this come into play? If you're paralyzed from the neck down, that's not a terminal illness.
No.
So would and if you said what? What would you say? Take me off of? And would a doctor have to comply with that if you're not terminally ill? Is the terminal illness the pivotal point?
It's incapacity. It's your body, what you want. If I am somebody who's not able to swallow, as depending on the level of disability, they're going to have to put a gastrostomy tube in. If I can't breathe on my own, if I have a high level cord injury and I have to be on a ventilator, again, that's a decision that I know that I've communicated, and to my medical power of attorney who I trust. And so, again, I don't want to focus on this. This is my personal decision. It might be controversial. A lot of people think, well, I would make a different decision. That's fine. Yes, please.
I'd like to ask another question about palliative care.
Yes, ma'am.
I have a mother, 102 years old.
Good Lord, good for her.
And she lives alone in her own house in upstate New York. There's not all that much wrong with her. Bad eyesight, she's very stooped over. Little heart problem. Would she qualify for palliative care, for a team of people to come in?
The question is that this lovely lady has a 102-year-old mom who is still living independently. She is declining, but slowly. She has some sight impairments. She's probably got some osteoporosis, which is causing her to hunch over. And the question is would palliative care provide services? The question is, would she still be alive in 2 years? Probably not. 104 is quite a bit, but you don't know. But there has to be a diagnosis. Usually palliative care will accept four diagnoses, 4 terminal. Lung disease, COPD, terminal cancer, Lou Gehrig's disease, and congestive heart failure. She might do it, if her congestive heart failure is bad enough, yeah, she would. Absolutely. Talk to her doctor. Services open up when you have a palliative. Excuse me?
What would the people who come there, what would they be?
Okay, the question is, if her mom had a palliative care referral, what kind of services would she get? What would they do for her? They can have a certified nursing assistant come in 2 or 3 times a week to help you bathe. They will have an RN coming in. They'll have a physician coming to her home, which avoids emergency room visits and hospitalization. Say, she wakes up in the morning and she can't breathe as well, and her legs are swollen. It's like, I think my congestive heart failure is not doing well today. A lot of people would ER it what in a palliative care situation, you call the doc, or they'll sometimes even have the nurse come over. I know that there are hospices that have special teams of an RN who will come to your home 24/7 to deal specifically with lung COPD and congestive heart failure acute exacerbations. And they'll communicate with the doctor, and the doctor will give them medical orders, will increase their, their, what do you call it, their Lasix, which is their diuretic, and you get services and you're not in a hospital. And it's comfort measures. It's all about comfort measures.
That's all she needs.
Yeah, and so talk with your doctor. At 102, up in a congestive heart failure, if the congestive heart failure is probably what's going to do it, ask her. She's not going to, 2 years, I can't predict, but 104, that's stretching it. So, yeah. Okay, anybody? Hello. Yes, sir. Please.
In the case of a person with Lou Gehrig's disease or something,
Yes, ma'am.
where a person doesn't want to live anymore, but they're not terminal,
Yes, ma'am.
what's the status of assisted suicide?
Illegal in Colorado. I do know that there are some states that do allow it. You have to be a resident, and I believe you have to have multiple physicians willing to sign off that it is a terminal condition. But being that Colorado is not a state that allows it, I am not as educated about what out-of-state folks have, so I can't directly answer that question. Yes, sir.
How does all of these things that you've been talking about relate to Alzheimer's disease? If I say I do not want to live with Alzheimer's disease, what can my medical power of attorney do?
Well,
what can I do?
Yeah.
That sort of thing.
The problem with Alzheimer's disease is that, number one, these people usually are enormously otherwise healthy.
Yes.
They are enormously healthy. They can live from 0 to 10, 15 years. Average, I think, is 7 to 10. And the decisions, again, they'll have the dwindles. And the decisions that you're going to make are, if they have a commensurate comorbidity like congestive heart failure, you're going to have to decide, okay, at one point do we not continue? If they end up in kidney failure, do we not go on dialysis? Those are big events. But the answer to your question is, most likely what will happen is they will live 10 to 15 years. They will end up with pneumonia because they're very sedentary. Or they'll end up with a horrific bladder infection, which goes into blood poisoning, and you get to decide on antibiotics as a medical power of attorney. But like I said, these folks are generally pretty healthy. It's amazing how long folks last. And we better be aware that there's a tsunami of people with dementia coming down the pike.
Janice?
Yes, ma'am. Yes, sir. You done?
Yeah. Let me just give one
Yes,
thought
please.
to that. I think if you have Alzheimer's and you have advanced directives, you could put in your advanced directives that in case of Alzheimer's, I do not want to be treated medically for anything other than pain.
Yeah.
So that would at least optimize things. If you get pneumonia, you can also state that you don't want a peg tube in your stomach for feeding, because sometimes Alzheimer's patients don't eat. You can specify things like that. But other than that, and the previous questioner asked about assisted suicide in Colorado, which we call aid in dying, and that is not legal in Colorado. It's only legal in Oregon and Washington, and to some degree in Montana. But there's no legality of that here.
What about Hawaii?
Hawaii, no, they just shot that down. That was just interpreted by the state attorney general in Hawaii, and he said no, it wasn't. There was a 1902 law in Hawaii that was meant to deal with people with Hansen's disease, which is sometimes known as leprosy, but that does not apply in this case.
Excuse me, what does illegal mean?
Illegal means if someone assists you in suicide, that person can get prosecuted under the homicide laws.
Well, you can take your own life, though.
You can always take your own life. You can always take your own life.